You're listening to the RC Executive Lounge Podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle. The views expressed by guests are their own and do not constitute endorsement of any specific product or solution.
Hi, everyone. Welcome to another episode of Season 2 of the RC Executive Lounge Podcast series. I'm your host, Praveen, and I'm super glad you're all joining us today. I'm very excited to welcome one of the most recognized voices in the mid-revenue cycle. Our guest is Tami McMasters Gomez, Executive Director of Mid-Revenue Cycle at UC Davis Health in Sacramento, where she leads health information management, coding, clinical documentation integrity, and revenue integrity across one of the country's leading academic health systems. In her role, Tami is responsible for the accuracy, compliance, and efficiency of the mid-revenue cycle, bringing coding, CDI, compliance, and finance teams together under a unified strategy and leveraging technology and artificial intelligence to drive sustainable performance. Tami is a nationally recognized leader and a sought-after expert on AI in the revenue cycle. Her program won the 2021 ACDIS Diversity in CDI Award. She received the 2022 ACDIS CDI Professional Achievement Award, and she serves on the ACDIS Advisory Board. She holds her MHL along with the CCDS, CDIP, and CCSP credentials and speaks nationally on predictive analytics and AI-driven decision-making in the revenue cycle. A few things set her apart. She made the bold decision to discontinue UC Davis Health's CDI and coding reconciliation process, driving a 33% increase in productivity, backed by coding accuracy near 99.9%. She has been candid that AI should augment her coding workforce, not replace it. And she launched the UC Davis Neurodiversity Coding Internship Program, creating professional pathways for neurodivergent individuals into medical coding. We will talk today about the biggest challenges facing the RCM industry and how to prioritize amid them, the role agentic AI is playing in the revenue cycle, and how she navigates difficult leadership challenges in a complex RCM environment. Now, let's welcome Tami McMasters. Tami, welcome to the show, and thank you so much for joining us.
Thank you so much, Praveen, and I'm humbled to be here. Thanks for having me.
Well, let's dive right in. With so many pressures on finance and RCM teams today, from payer delays to staffing gaps, how do you go about setting your top strategic priorities? What is your framework or approach to thinking of strategic priorities in the first place?
Yeah, so I think in the mid-revenue cycle, I try to anchor priorities around preventing revenue leakage before the claim is ever dropped or coded. So thinking about how we can be more strategic about working more proactively rather than reactively, right? So thinking about frameworks like authorization and medical necessity accuracy. Are we getting it right the first time based on payer rules, clinical criteria, documentation? And that includes clinical documentation integrity, kind of real time. Are we supporting the level of care and the services billed? Not retrospectively, but during the actual admission of the patient. So more upstream rather than downstream, and then downstream denial prevention. What avoidable denials look like, and which ones are originating from from breakdowns within the mid-revenue cycle. We also rely heavily on denial root cause analysis tied back to mid-rev cycle processes, payer policy intelligence, targeting high impact areas like outpatient procedures, infusions, imaging. But ultimately my goal for the mid-rev cycle is to act as a control point that protects revenue before it even becomes at risk from an AR perspective. And, I'm happy to provide some examples there, as well.
Makes sense. And every organization has to make tough choices, right? Especially someone at your level, you're probably going to get 20, 30, 50 initiatives from your team members. And your team's bandwidth is always limited. So you obviously have to pick a few every year and have to say no to some really good initiatives. Maybe can you share an example where you had to say no to a really good initiative in favor of something a lot more critical in the last 1 or 2 years?
Yeah, so I think we had an opportunity to expand retrospective clinical documentation review programs, and it would have improved capture after the fact, but it does require significant resources. And so instead, we prioritized adoption of technology in that space, using real time tools to kind of sit as a safety net behind our CDI team, right? So looking at where there's missed either query opportunities or missed coding opportunities. And so this is really where we're looking at automation and technology to augment throwing labor resources at it, right? We didn't say no to increasing staffing because it wasn't valuable, but really looking at how we can leverage technology at the same time being mindful of budget, right? And what that looks like, as most institutions are challenged right now in this space.
Makes sense. And it seems like in that example, you were leaning towards technology to solve a valuable problem. A related question there then is, and that's the flavor of the previous question that I want to bring. There is a bit of a tension between innovation requirements, which is a technology investment, and operational requirements, which are short-term requirements, right? How do you as a leader navigate that tension? Because your technology investments are great, would have amazing ROI, but they're also risky bets versus operational requirements where you have immediate requirements and the operations team is potentially banging on the door requesting for a solve. How do you manage the tension between the two teams?
Yeah, I think ultimately we tend to play this a little bit more conservatively comparatively, right? We look at how we can engage with a vendor or an automation or a technology in some type of proof of concept so that we can actually gauge what the yield is in return, right? What are we investing from an IT infrastructure build perspective? What are you investing from a staffing team engagement perspective? And what is the yield in return? Are we going to see the yield we're expecting to see, or is this a product that has kind of overpromised and underdelivered? So I think it really is important for organizations to consider some type of proof of concept with a vendor so that the vendors can actually stand up the product and kind of yield or prove that return. And you can get a feel for what it's going to take to manage this. And then you take that back to your leadership and say, well, we've done our due diligence, we've looked into this, and this is what realistically we can expect to see in terms of predictable outcomes.
That's actually a great way to like test the waters and then go deeper as you see the ROI. Thank you so much for that powerful insight.
Mhm.
Now, we hear a lot about um, programs like patient financing and denial prevention in almost every major RCM event. Like you go to HFMA, MGMA, HIMSS, wherever it is, these topics show up a lot, right? Where do these kind of programs, and we also hear from some leaders that these are typically long-term multi-year initiatives. How does your organization approach these initiatives? Where do patient financing and denial prevention fit into your strategic roadmap typically?
Yeah, so in mid-rev cycle, I think we play a different but critical role in both, right? Denial prevention is central to everything we do. We have a denials program manager, and that program sits within revenue integrity. But we have to really, as I kind of coming back to this, have to look at being more proactive upstream instead of reactive, right? We can't wait for the denial to happen. We need to think about how we can ensure authorization accuracy up front, align documentation with payer expectations up front, and then helping to reduce that medical necessity and technical denials will result. So, patient financial financing intersects through authorization and the clarity. So when authorizations and coverage are clear up front and we've done our due diligence up front, we can expect to see more accurate estimates. This will eventually reduce surprise billing and supports financial engagement. So while we don't own financing, we directly influence it, I think, by ensuring that we have cleaner claims and more predictable outcomes with trying to plug those gaps upstream rather than being reactive and writing appeals. And obviously, there are still advantages to obviously appealing things in the retroactive space because you have to. There's really no way around it, right? Those are still going to be opportunities, but the way I think about this is and operationalize this is to take that information, right, and root cause, and then continue to plug those gaps upstream where we can.
Makes sense. That's a great stopping point before we move to the next segment. Let's take a short break. When we come back, we are going to talk to Tami about a recent initiative that her and her team led, what challenges they were solving for, and how they went about the implementation. Let's take a short break.
This episode is brought to you by rchq.com. That's ARCEEHQ.com, the agentic AI platform helping healthcare providers improve financial performance by simplifying patient financing and financial assistance. From faster approvals to fewer write-offs, RCHQ makes it easier for patients to pay and for providers to get paid. Learn more at rchq.com.
Let's dive right in. Tami, I'd love to dive into a recent initiative that you and your team led. Maybe let's start with what challenges were you solving for?
Yeah, so I think what we're really diving deep into right now is focusing on how we can help with documentation around medical necessity and authorization related denials and some of those high cost outpatient services. So the issues could range from frequent payer policy mismatches to manual inconsistent authorization workflows, maybe documentation not fully aligned with clinical criteria. We don't have a covered diagnosis for some type of outpatient procedure or test that's being done. And so really a lot of that is driven around documentation and making sure, again, that we're proactive upstream with, those frequent payer policy mismatches and that manual inconsistent authorization workflow. So what we're trying to do is we're trying to build an intersection between revenue integrity, authorizations, denials, and then our CDI team so that we can address these things, excuse me, as I mentioned, upstream. That is, we throw people at it, we throw processes at it, but we also look at where we can partner, finding a solution, looking for real-time payer rule guidance at the point of decision-making, integrating with provider workflows, not just the back office teams, and looking for ways that we can maybe build out predictive alerts before the services are rendered, right? A key factor is making sure that you choose the right tools that bridge that clinical and revenue cycle team, and that we don't operate in silos. So bringing all those teams together. It's a big ask, and there's still going to be things that I think slip through the cracks, and those are things that we can use to improve outcomes upstream and continue to plug the gaps, as I mentioned.
Makes sense. And once you identified this challenge, and this sounds like a really big challenge, not just for your organization, but most organizations I'm sure would be facing, how did you go about selecting a solution or a partner? Because in this case, whenever there's a problem of this scale, there is again this tension between build versus buy. How did you go about resolving it, and what was the outcome there?
Yeah, so I think first and foremost, we had to identify some of the pitfalls and surprises, right? So there's a few big things or lessons learned, I would say. So making sure that you have that clinical engagement is going to be critical. That mid-rev cycle success depends on physicians and clinical staff alignment, and not just the revenue cycle teams. And really knowing and being, I think, conscious of the fact that standardization is harder than expected. Variability in service lines and payer rules adds that complexity layer, and then upstream dependencies are surfaced quickly, right? Scheduling, order entry, all of those things. So I think what we are doing and how we're approaching this is kind of a triad. We're looking at people, process, and technology, and picking the right technology may not be the only solution, right? It might be that we need to build or integrate into our EHR specific workflows that are clinically more on the physician side of the house. It may be that we need to set some edits on ordering for specific medications or drugs that need a covered diagnosis, or it may be that we need to implement an ABN process that is something that isn't necessarily being actively deployed in the clinic setting, like it would be maybe in the emergency room or other areas. So I wanted to just level set that it's not just selecting a technology, it's also making sure that you have the right people process in place, and then selecting the technology to fill the gaps where you do have an opportunity. So doing that requires a few things, right? You need to look at the various vendors in the space and what their offerings are. Also looking at what you have in your current tech stack within your EHR, depending on whether you're using a large EHR that does have a single billing operation built in it, whether or not there are tools that exist in your current infrastructure that you can leverage, and then making the decision.
Makes sense.
And then measuring that impact and tracking, right? And making sure that you're yielding that ROI, right? You may have a vendor that promises, right, a yield and ROI, but you have to measure that, look at that outcome.
That makes sense. And as you look at the implementation for this project, what did that look like? Were there any unforeseen pitfalls, surprises, or lessons you learned along the way that you could share with our audience?
Yeah, so to be fully transparent, we're actually in the process of looking at the various vendors on the technology side, but we plugged the gaps that I mentioned upstream with people and process, right? We've leveraged all of the tools we can within our EHR, and we have all of the people in place that we need, and the collaboration with the clinical teams, the patient access teams up front, the mid-rev cycle, and the back-end teams all kind of working together on a large a team. It's actually it's called the write-off denials avoidance task force. And we meet regularly. We go through the different documentation schemas, the different denial reasons, and we're working very collectively. Things are being routed to work queues. And we're at the same time, while we're doing all of this, we're interviewing various vendors in the space to determine what is going to be the best fit for organization, considering we already have a foundation in place. And what is it that we're trying to solve now? Now that we have all of these things in place, what technology are we hoping to adopt, and what are we hoping to achieve? So those are the future kind of questions in terms of what we're hoping to solve with adoption of the technology now that we have the people and process in place.
Makes sense. And as you proceed with execution in the future with the vendor, um, how would you track success for a program like this? And obviously, program success, at least in my mind, there are multiple layers, right? There's the financial layer where there's ROI, yield, and all. And then there's also an operational layer where there's going to be a change in operational metrics and potentially also to denial metrics. What does it look like in terms of tracking success for a program of this scale?
Yeah, so I think we would look at medical necessity denial rates. We would look at first pass claim acceptance tied to kind of mid-rev cycle edits, maybe avoidable denial dollars that have been prevented. And some of those early outcomes may be reduction in targeted denials, fewer retrospective authorizations or retroactive authorizations. Maybe we would look for like improved collaboration between those clinical and RCM teams. I think we're also, emphasizing leading indicators, because by the time you see a denial, it's already too late. So, like I mentioned, being more proactive rather than reactive. So, measuring those things right now, and then once we have what they look like, having a baseline without the technology, and then measuring those things with the technology will help you determine whether or not you're yielding that ROI.
Makes sense. And
And
just
just to name a few,
that makes sense.
of these, yeah.
That makes sense. And just for my understanding, is it also true, from my understanding, that if the denial rates go down based on this initiative, there is a possibility that the cash days on hand also goes up?
It can be that our CFB goes down and our cash goes up, but it depends on the workflows, right? And how you work to prevent some of those avoidable denied dollars upstream rather than being, like I said, reactive. So I don't know if I understood the question, or if I answered the question, because it sounded like you said our dollars would go up, but I would expect our CFB to go down,
Makes sense.
which is yeah.
That makes sense. Excuse me. You definitely answered the question.
Okay.
With that, Let's move on to the next section. In the next section, we are going to talk to Tami about the role agentic AI is about to play in revenue cycle and how it can improve outcomes for the hospital as well as for the patients. Please stay tuned.
The RC Executive Lounge is proudly sponsored by rchq.com. That's ARCEEHQ.com, where agentic AI is transforming how providers manage patient payments and financial aid. Providers using RCHQ are seeing more collections, less manual work, and greater access for patients in need. Visit rchq.com to learn more about the platform and schedule your personalized demo.
We are back online. Tami, I want to shift gears into technology. What role do you see agentic AI playing in revenue cycle, or maybe even more specifically in mid-revenue cycle, as you look at the next 12 months versus the next 3 years and 5 years?
Yeah. So in the mid-rev cycle, we are already using AI to become a real-time decision support engine. Some of the examples would be around autonomous coding. And we just actually went live with 2 different vendors in the autonomous coding space. So we're using one vendor to tackle more of an entry-level type coding, where it's specifically around ancillary coding, radiology to be exact, where these are more entry-level, repetitive type coding for things like mammograms, things like CT scans and ultrasounds, where it's high volume, but it's low complexity and low risk, but you still end up throwing 15 FTEs at the work because the volume is so high. And what we're hoping to accomplish, right, is to reduce the administrative burden with having coders do this type of work. At the same time, we're trying to solve for growth, right? We're seeing a lot of growth in our organization, and the volumes that we're seeing with these types of services are increasing by a third, right? So do we continue to hire more coders where we know there's a national shortage of coders, it's difficult to find these type of people, or do we augment growth with technology and allow for autonomous coding to come in and code these accounts in these more low risk areas where the complexity isn't there? The other thing that we are ensuring from a compliance and risk mitigation perspective is making sure that our accuracy thresholds, right, are around the 90 to 95% range. And what that means is the autonomous coding engine will code the code, but if it's not confident at that 90 to 95% hold that it's accurate, it will route to a work queue for a coder to do a second level review behind the AI and make sure that the coding is correct and that there's updates needed as appropriate. So we have a human in the loop to ensure integrity with that process. I think the biggest shift and then we have a second, with that will be that making sure that we also have a QA process in place for that 10% or that 5% risk that we're willing to take, right, with that 90 to 95% accuracy. So even if you feel confident in letting these things go direct to bill, meaning no coder needs to stop it in a work queue, it's autonomously coded and it's passing on through, you still should have a policy around auditing AI in place, which we have, and also a QA process that is auditing 100, not 100%, but that 20% variance or that 10% variance that you're willing to take the risk on. At the same time, we're also going live with another autonomous coding solution that is coding for E&M in the outpatient space, in specifically like your outpatient clinics. So your physician office visits, those more low complex annual well child, annual health screens. And this autonomous coding solution will autonomously code E&M diagnosis and modifier coding. And so we're seeing great results with this. And as the engine becomes smarter and we start to yield that accuracy threshold that I mentioned before, we hope to also solve the problem around growth and labor reduction with regards to needing to hire more staff, especially in the current climate where we have a national shortage.
That makes sense. And AI, agentic AI specifically, has two types of applications within claims denial management, or more so broadly in RCM. One, there are places where it could bring incremental improvements like a 5%, 10% improvement, and other places where it could truly bring like a 5x, 10x improvement, right? Significant step function improvement. Um, what do you think are the areas where agentic AI can really bring that step function improvement within broader RCM or more so within mid revenue cycle?
Yeah, I think the biggest shift will be embedding intelligence into clinical workflows, not layering it afterwards. So some of the game-changing areas I think are real-time documentation guidance aligned to payer criteria, um, predictive identification of authorization risk, and automated validation of orders against maybe payer rules. At the same time, I think ambient technology, we are already using a form of ambient technology. It's mostly used in the outpatient setting. To mitigate administrative burden around documentation for our physicians. But I do think with the advancements in that space, we can start to see some of the ambient technology also embed some more real-time guidance around documentation. I think the other big thing that we should be watching for is how we navigate governance around AI. There are already several assembly and state bills in the state of California that prohibit the use of AI in clinical care decision making, and that can get really muddy when we talk about, medical necessity reviews. That when we talk about CDI work, right? Because CDI is driving clinical documentation that is used then in the chart to treat and care for the patient. So there's a lot of governance that we have to keep in mind around how we embed these intelligences into our clinical workflows.
That makes sense. And one last question for this section before we move to the next section. What other technologies are you exploring actively or watching personally closely that you think would be applicable for revenue cycle or mid revenue cycle? This is outside of AI. Anything outside of AI that seems interesting to you?
Yeah, I think anything that has a clinical and an RCM workflow integration platform is something we should be looking at. I think real-time eligibility and authorization tools, whether it's AI or not. Um, and then anything that's integrated and embedded into your current EHR workflows. And then, payer transparency tools, policy engines, rule libraries, things like that can be really helpful as we start to see payer behavior shift.
Makes sense. Payer transparency in particular seems like a focus for a lot of people, given that there is just so much change happening in that area. So that totally makes sense. One last question. Is there a metric that you as a leader obsess over every morning? That so much so that if that metric goes down, there's so much tension in the organization. Is there such a metric for you?
Well, there's three. There's three that kind of keep me in AR, obviously, CFB, which is our cash, and then because I'm in mid rev cycle, I am paying close attention to denials and charge lag. So those are the key metrics that I kind of obsess over daily. And one of the things that I implemented at our organization is a daily huddle called High Pay, and it's meant to focus on these four metrics and look at where in the system something is being held up. Right? Is it sitting in a peri-op work queue waiting for the OR logs to get updated so that the charges can drop on the claim? Is it sitting in a coding work queue because a coder is waiting for documentation? Is it, where is it sitting in the organization? And then we can escalate and take action, right? Especially if it's a high dollar case that's impacting CFB, or especially if it's an older account that's impacting charge lag. So every day we get all of the key stakeholders on this call, and everybody is held to kind of an expectation around escalation and addressing this. And sometimes they get escalated on up to our VP, depending upon what it is that we're trying to solve.
Makes sense. With that, let's take a short break. When we come back, in our last segment of the episode, we're going to talk to Tami about complex leadership challenges that she has navigated in these types of complex RCM environments. Let's take a break. We'll be back soon.
Today's episode is sponsored by rchq.com. That's ARCEEHQ.com. If you're looking to reduce friction in patient payments and increase access to financial assistance without overwhelming your revenue cycle team, RCHQ's agentic AI platform might be exactly what you need. Head to rchq.com to learn more.
Welcome back. Tami, change is hard. It is especially hard in complex RCM environments. How do you, as a leader, build momentum for change across various different teams, especially given that when we think about revenue cycle, it's a highly cross-functional area. There are so many teams to be coordinated with. So how do you navigate building momentum for change?
Yeah, I think in mid-rev cycle, it's unique because it crosses clinical and operational worlds. So, really focusing on bringing data to clinicians in a meaningful way. And that really could be showing how documentation impacts denials and patient care delays, and maybe even how it impacts our rankings in U.S. News World and Report, or our quality outcomes and in Leapfrog. And some of that is actually patient facing, right, and can be used in a customer type way to determine where they want to receive their care, right. No longer are the days where we can't be selective about where we choose to have our care. I think embedding change into workflows, not adding extra steps, and that change management is really going to be key, right? So building momentum also does rely heavily on change and change management. And then I think celebrating prevention, not just recovery, right? How well are we doing at working upstream? So moving your focus as far upstream as possible, so that we can yield every dollar prevented from a denial in the mid-rev cycle is going to be exponentially more valuable than one recovered later. So I think those are the kind of the building blocks for how we can yield momentum or move momentum for change.
Makes sense. If you could give one piece of advice to a fellow RCM leader or a CFO tackling similar challenges, be it in denials management, patient financing, financial assistance, or any other area of RCM in general, what would it be?
Yeah. Okay. So I have two things here, but the first one I think I've mentioned, and this is kind of been the tone of this podcast all along, is move your focus as far upstream as possible. That being proactive rather than reactive, as much as you can, right? But I also think as you're exploring technology and adoption and investments into different agentic AI or AI tools, that you do have that proof of concept, and that you also have a human in the loop, right? We're not going to plug and play and walk away. We need to have a human in the loop. We need to have somebody behind the AI, auditing the AI, governing the AI, and making sure that we're not putting our organization at more risk, right? So I think those are the two, I think, from my perspective, that really I think you can have immediate change in your organization today by doing those things.
Makes sense. One last question to close out the episode. Is there a recent book, a podcast, a framework you might have read somewhere that significantly influenced your leadership thinking in general when you look at RCM or even specifically within mid-revenue cycle?
Yeah, so there's, I don't know if you're familiar with the book, The Speed of Trust, but that's one that has really helped my foundation in terms of how I lead, right? Making sure that you are the people that you're working with, one, trust you, but two, that you have the trust of your peers, and that you trust your peers, and that you're working together by creating collaborative relationships built on trust. Because without trust, I don't think you have a whole lot of success with change management and other things downstream. There's a second book that I read that it kind of carries over into the professional world, but it's called Just Let Them. It's more of a self-help book around how you cannot control the way people react or the way people behave, but you can control the way that you react and the way that you behave and the way that you choose to move. And so for me, I kind of live by that mantra around, hey, if you're upset, I can apologize and try to make the situation better and do what I need to do to get us to a place of mutual understanding. But I can't really control how the other person reacts or perceives the way that I move. So I think it's just a matter of making sure that you stay in that space of understanding and trust. And I think besides the understanding and trust, staying in a place that you are looking at all perspectives and taking into consideration all perspectives. And even sometimes that empathy piece of this needs to come in. And you have to think about the fact that others may not be looking at things from the same lens as you. They may be dealing with something personal that's driven the way that they view a situation. So we have to really, I think, be mindful as leaders of the circumstances that sometimes surround conflict.
Makes sense. The last point that you made around trust and empathy, that's a really powerful insight. Tami, thank you so much for sharing such powerful insights with our audience. And thank you so much for joining the show today. Um, I'm really glad I did this episode today because just as I was listening to you, I was able to think of a lot of insights that I learned from this episode personally. And I'm sure our audience are taking back a lot of interesting insights that they can use themselves in their day to day. So thanks again for joining the show, and I hope you can join us in another episode, maybe focusing on a more specific topic like claims journal management or patient financing. But until then, thank you so much.
Thank you for having me. I appreciate it.
The views expressed by guests are their own and do not constitute endorsement of any specific product or solution.